Yes. So I have no conflict of interest to declare. As I told you, I'm a guy, but also a minimally invasive gyne surgeon, means I do lots of laparoscopy. I work with North Park Hospital in Barwa, and I'm the current president of AOGU. That's the membership linking all gynes and obs in Uganda. First of all, one of the biggest updates in Uganda or worldwide is the discipline of gynecology. Initially, gynecology was being practiced by surgical oncologists, but over the last 20 years, the gynecologists have taken over that area, and so the field of gyne-oncology, also sometimes called gynecologic oncology, has come up, and those trained to be in that field are called gyne-oncologists. So this is a relatively new field, less than 20 years old, and in Africa, it's just starting to pick up. So gynecologists basically have knowledge to diagnose, treat female cancers, particularly cervix, ovary, endometrial, vulva, and vagina. So this field requires specialized training, anywhere from 1 year to 3 years of training. Train on is surgery on reproductive organs, radiation, and chemotherapy. But also because gyne cancers spread to non-reproductive organs like the intestine, the ureters, the bladders, we also do surgeries. We are trained in surgeries on the intestines, like colectomies and urinary tract system issues like managing things like that. Of importance also, a big chunk of our work comes in helping general gynecologists when they have major surgeries which are complex. For example, they are placenta cureters, they are doing surgery for endometriosis. And of importance to note is that surgeries performed for cervical cancer and other cancers, if performed by gynecologists, the outcome is much better than if performed by general gynecologists. But remember, this is an emerging field, and there are, I think, about 7 gynecologists in Uganda. So the gynecology service usually starts with the gynecologist, and their role is generally to make a diagnosis. So they will screen women, and then they will diagnose one who has a cancer, and then refer. I'm talking about cancers here. Precancerous lesions or pre-malignant lesions can be dealt with at this level. But the cancers are better referred to the gynecology unit. I'm aware that Ginger Hospital has a gynecologist there. So when you talk about gynecology, it's not just the gynecologist. So there's the gynecologic oncologist, there is the medical oncologist who gives the chemotherapy. So our work is to diagnose, stage the disease, and then prescribe treatment. Medical oncologists give the chemotherapy. We need pathologists because one of the problems in Uganda is we have poor pathology reports, and that affects the quality of work and prognosis for the patient. Someone who gives radiotherapy, radiology is a problem in Uganda, so diagnosing and staging become a problem. Palliative care, and sometimes we need general surgeons. So all this is called gynecology, not just the gynecologist. What has changed? Recently, about 3-4 years ago, FIGO changed the staging of cervical cancer. The last version was implemented in 2009, but now we have a new staging. However, this has not yet spread widely in the country or internationally because people are still getting used to it. The reason for the change was that as they kept doing more and more research, but also looking at previous studies, there were differences in survival for some of the stages. So they made a decision to actually reduce them. For example, the new things in the new staging are around stage 1B. Previously, it had 1B1 and 1B2, where the cutoff was 4 centimeters diameter for the tumor. But now the current guidelines or the current definition says the tumors of they are less tumors than 2 centimeters diameter, then they are 2 to 4, and then 4 centimeters. Now, people who have less than 2 centimeter diameter tumors tend to do much better than those who have between 2 and 4. So a category was set up, which is called 1B3. I think whoever is maybe mute the microphone. So categories were added in here to become 1B1 is less than 2 centimeters. These ones have a different prognosis from those between 2 and 4 centimeters. Then this one became then 1B3. The second change was in the previous classification or definition, there was no lymph nodes taken care of. Later it became known that the lymph nodes actually have prognostic value. So they brought out stage 3, which was not there previously. So the small dashes there mean it was not there. Otherwise, the rest of the staging remains the same. So when we say stage 1A, it means the cancer is confined to the cervix. The tumor is confined to the cervix and is only seen under the microscope. When we say stage 1B, the tumor is still confined to the cervix. The difference will be the size of the tumor, less than 2 centimeters, 2 to 4, and more than 4 centimeters, but still confined to the cervix. When we say stage 2A, the tumor has spread to the upper vaginal wall, or the upper third of the vagina. But stage 2A1 and stage 2A2, the difference is in the size of the tumor. One tumor is less than 4, the other tumor is more than 4 centimeters. These tumors are still surgically resectable. We normally call them, so this stage 1A, stage 1B, and stage 2A are normally called locally advanced cervical cancer. So from stage 2B, we cannot, the tumor has gone beyond the vagina into the surrounding parametria. Parametria means the tissue around the uterus. 3A, the tumor has gone into the lower vagina. 3B, the tumor has gone through the pelvic wall and is sometimes affecting the ureters. So you may get an enlarged kidney or hydronephrosis. 4A, the tumor has spread either to the bladder or to the rectum. 4B, the tumor has gone to other organs. Now, because of the change in staging, it meant even the imaging for cervical cancer had to change. Now, previously they would say ultrasound, CT. Now, the imaging of choice for cervical cancer since about 2016 is magnetic resonance imaging, MRI, which is the preferred modality to determine if the cancer is operable or not. But you can still use transvaginal ultrasound scan and CT scan. The TVS or the ultrasound scan must be in an expert hands. Otherwise, you never get good results. CT scan, the image is poorer. We also do have what we call the PET CT or PET MRI scans, which are used to determine distant metastases. So the main change here is that the imaging of choice now is the pelvic MRI to determine operability. We have MRI in Kampala, and I think it must have something, I'm not quite sure, but MRI is available. So women with early stage cervical cancer should be offered an MRI if they can afford. If not, ultrasound. So what does an MRI help us to do? As we said, it is the imaging of choice. It can help us determine the size of the tumor. So this is the uterus here. That is the endometrial lining and the cavity. And then this is the tumor, the cervical tumor. Behind is at the front here is the bladder. Normally, when you're looking at these organs on MRI, we have what we call tissue planes, and that's why the MRI becomes very important. Tissue planes, like the black line here, the white inside is urine with the contrast. The black line is the bladder wall, that one that you're following is the bladder wall. Now, the tissue in between is called the fat plane, which is better pronounced here. That is called the fat plane. So it means the tumor, like here is the tumor. This is a tumor of the cervix, has not crossed the tissue plane into the bladder. It means there is no parametrial spread. The connective tissue around the uterus has not been affected by the bladder. Otherwise, you will see this color in those areas. The same thing with the rectum. This is the rectum, and then the anus. The fat plane, this color white is fat. So the fat plane is maintained. So it means this tumor is resectable. The tumor can be to the bone. So whether you're doing a EUA, it would not help. Now, because tumor spreads, there are factors we consider before we do surgery or after surgery, determine if we shall give this patient radiotherapy or therapy. One of them is what we call lymphovascular space invasion, LVSI. So when we say somebody has intermediate to high cervical cancer risk, it means they either have at least two of these factors in this range here. If we say it's a high risk, these ones we all have to give them radiotherapy. If here they must have two of these, but high risk they only need to have one. So any tumor more than 4 centimeters, high risk, they must give them radiotherapy. But this is good after surgery. If they have positive lymph nodes, they must get radiotherapy. Now, what has changed majorly in cervical cancer management is the management of early stage. Now, early stage is 1A and 1-2, which is microscopic. If you look back at the staging, 1A is less than 3 millimeters deep into the cervix. 1A is between 3 to 5 millimeters. That's the definition there. The depth of invasion. So those two, the diagnosing stage 1A and stage 1A2 is done by a cone biopsy. A cone biopsy means you remove a cone-shaped part of the cervix. But to make this proper diagnosis, you need an expert review by a pathologist who looks at the depth of invasion. They assess the margins of the cone, and the margins are assessed for both invasive, which is cancerous tissue, cancerous cells, but also pre-invasive disease, which is CIN1, CIN2, CIN3. And of course, they also assess lymphovascular space invasion in that sample. So when we say cone biopsy, we cut a cone off the cervix. This is the endocervical canal, or what we call the os here. So we cut a cone, and this is what it will look like after the procedure. So the cone has been removed, and it will determine how we move forward for that patient. Now, there are also lymph nodes that the cancer spreads to. So uterine cancers or cervical cancers will tend to spread to the parametria, which is just loose connective tissue around the uterus and includes the ligaments that normally cut off at hysterectomy. There are nodes in the fossa of the fossa. There are nodes in the internal iliac. Then they move along the vessels all the way to the aorta, and finally they spread upwards. So when you're doing treatment for nodes, we try to remove all this group of nodes for the cervical cancer. Now, of importance again, what has been found out and why these groups, why the new staging has come up. For people with stage 1A1, this one, the earliest form, microscopic, basically they don't have pelvic lymph node metastasis and parietic lymph node metastasis. People with stage 1A2, pelvic lymph nodes are about 4.8%. So most of them, 95% of them, don't have lymph node spread. And this will determine how we treat them. And less than 1% of them will have parietic. Parietic nodes are the ones which are higher. Pelvic lymph nodes start from this area, from the common iliac downwards. As you go higher, stage 1B, the lymph node percentage increases. So still, a large number of patients don't have lymph nodes in this area, over 84%. Stage 2A, stage 2, about a quarter of them will have lymph nodes. So just keep that in mind as we talk about advances. So what has changed in managing stage 1A tumors? So first of all, we do a cone biopsy. When we do the cone biopsy, the most important factor we are looking for is lymphovascular spread. If it is present, if it is positive, we go ahead and do a pelvic, the PLND means pelvic lymph node dissection. And now what has changed is we stopped doing them. There is somebody with a microphone which is on. So we do laparoscopic. So minimally invasive surgery is a very important skill for the gynecologist. Laparoscopy, I know somewhere in Uganda, somebody has a laparoscopic tower. So we do a lymph node dissection laparoscopically, and while on the table, we send these lymph nodes for pathology, what we call process section. So you sit on the table, they are sent to the pathology lab, and they are ready immediately to know if the lymph nodes have a tumor or they don't have tumor. If they don't have tumor, then literally you have cured the patient, so you just follow up. But if the lymph nodes have tumor, you don't proceed. You just remove the ovaries. You reposition the ovaries, what we call laparoscopic ovarian transposition. You remove the ovaries from the pelvis and transfer them almost to just below the ribs, just around the flexures of the colon. The reason for removing the ovaries is because for patients who have lymph nodes, you want to do radiotherapy, and you don't want to destroy their ovaries. So you reposition them. Now, for people who have where the lymph nodes, lymphovascular spread in the colon biopsy is negative, you look at the surgical margin. What is the end of the margin looking like? If the margins are positive, you can repeat a cone and shave that area where they say the margins are positive, or do what we call a radical trachelectomy. So normally, when we are doing these things, it is a one-step procedure. I'll go to theater, I'll do my colon biopsy, I send the colon biopsy for a present section. They will tell me there is LVSI. If there's LVSI, I proceed and do laparoscopy to remove the lymph nodes in the pelvis. I still send them back to the lab. They check them for lymph nodes, if they are positive or not. The same thing here. If it is absent and there's no lymphovascular space invasion, we look at the margins. If the margins are positive, I just continue and do a repeat colon biopsy or a radical trachelectomy. Trachelectomy means amputating the cervix. If the margins are negative, I'll follow up. So this is what I mean by ovarian transposition. These are done laparoscopically. We don't do them open anymore. Though some people may still do them open. So this is a one-step process. That is now the advance that I'm talking about. So we remove the ovaries from there, and we keep dissecting their ligaments so that we can move them to just below the flexure. Because the area where in the pelvis is where we shall do radiotherapy. Any woman who is not yet menopausal, we don't radiate their ovaries anymore. We try to preserve the ovaries so that we maintain some fertility. We can now harvest eggs from the ovaries, but also preserve their hormones so that they don't go into menopause. So we remove the ovaries and put them up and then do our radiation in the pelvis. So that's one thing that has changed. So stage 1B, remember stage 1B was reclassified for people who have tumor size less than 2 centimeters and they still desire fertility. Stage 1B, we still do a biopsy or a colon biopsy. This one's also amenable to a colon biopsy. And then they don't have lymphovascular spread. We go ahead and still do the laparoscopic pelvic lymph node dissection. PLND means pelvic lymph node dissection. And send it for present section while we wait. This is about half an hour, 1 hour of waiting. If the lymph nodes are positive, for these patients who are stage 1B, we upstage them to stage 2. And then we do the radiotherapy. If the lymph nodes are negative, we do a trachelectomy. I said here that before we used to do radical hysterectomy, but now we can conserve the uterus and just amputate. That's what we call a radical trachelectomy. Trachea means amputate. This is what we mean by tracherectomy. Just amputate just below the level of the vessels for the gynecologist. Then we stitch the vagina to the stump of the uterus. So this sample, this is a stage 1B tumor, which you see there. And this is a cervix up to there, that level. So not all women who have cervical cancer should go for a radical. That's why it's important to send these women to the gynecologist. If we have to do a radical hysterectomy, then we have to remove the parametria, which are the ligaments surrounding the uterus. Now, anything below stage 2A, we again remember that before we just open and do radical hysterectomy and a pelvic lymph node dissection. These days, with the advent of laparoscopy, we still do a laparoscopic pelvic lymph node dissection before and send this for frozen section pathology. Now, they will give us a quick answer in about 1 hour. And if the lymph nodes are positive, we abandon the surgical procedure. We don't do the radical hysterectomy. And we send this patient for chemo radiation. That is a change there. If they are negative, if lymph nodes are negative, it means proceeding with radical hysterectomy is of benefit to the patient. So you go ahead with radical hysterectomy. But if lymph nodes are positive when you do it, abandon procedure and move on. Because chemoradiotherapy will be better, but combining radical hysterectomy and then later chemoradiation will cause also complications for the patient. We also have now what we call targeted therapy. And this one is specifically, these are drugs that target cancer genes, or they target proteins from the cancer cells, or they target the environment in which the cancer is born, or things which help the cancer survive. So these treatments either will block the growth or the spread of the cancer, while simultaneously doing damage control and not killing the normal cells. So these are normally used in recurrent cancers, or where we have failed chemotherapy. There is somebody doing something somewhere. So most of these, like bevacizumab, is a targeted therapy, and it can be combined with the normal chemotherapy that we give in cancer patients. The other one that has come up now is the biological therapies or immunotherapies. These are immune boosters. They boost the immune system of the body, either by improving, targeting, or restoring function to fight the cancer. So one of them is pembrolizumab. These are available locally, but not very commonly used, and they're very expensive. Joyce, you're doing something with the presentation. Then we go to cancer control. So cancer control in Uganda, especially, and prevention has remained chaotic. In the East, I know RIGHTS is offering or is trying to scale up BIA usage and thermal ablation. But as a nation, we are struggling to control the cervical cancer epidemic, but also to prevent. Now, what we need is to control and prevent is to increase the coverage and the timeliness of treatment and management. The other one is to increase cervical cancer knowledge and competence of the health workers. So many health workers are managing cervical cancer when not competent or don't have enough knowledge about the cancer. That is why you have the gynecologist, and I know there's one in Ginger Hospital. You have interventions to increase cancer knowledge and awareness among women. So for us to control, we need those three: increase coverage of the services, increase knowledge and competence of the health workers in prevention, VIA, colposcopy, cone biopsy, lip, and the rest, and also to increase knowledge and awareness among the women so that they can actually seek service. Now, Uganda has a plan developed in 2010 that deals with prevention and control, and that plan is online. You can read it. That is the plan. It is online, you can read that plan. And it gives what the government wanted to do. And they thought they would do advocacy, prevent HPV infections, screen, treat, palliative care, and then evaluate. And they had very ambitious goals. I hope this you can see. The ambitious goals were 90% of Ugandans will be reached with uniform IEC materials about the cancer, 80% vaccination for that age group, 80% of women between this age group screened and treated for lesions, 80% of those women who have lesions are treated, and so on and so on and so on. But those were very ambitious targets. We don't have data if those are have actually been done. So there's a document that guides. However, despite this document, we don't have a national screening program. So in Busoga, I think I would commend rights for the work they are doing. Then we have issues of consumables. Consumables remain a challenge in providing cancer care, especially spatulums, acetic acid, colposcopes, thermal ablation, operative equipment. So there's a challenge there. The other thing which was meant to increase coverage and timeliness in Uganda was the Uganda cancer. This one of 2016. So be aware that there is an act, and in this act, the government or the parliament and the state gave the UCI the power to regulate, implement, and so the act is a bit odd because you cannot be the regulator, you're the implementer, you're the punisher, you're the judge, you're the lawyer, so there's something wrong with the act, but it's a good act to try and increase coverage. Their coverage as part of the institute is to train in their functions. One is to develop policy for preventing, diagnose, and they have tried in this area, undertake and coordinate prevention, oversee management of all centers offering cancer care, establish and manage regional centers. I think this have actually done a very good job of in trying to set up the centers. But they have challenges because of other issues. So first of all, they have inadequate funding. They had some success, and I think in Jinja they have a center there with a gynecologist. They have a fellowship program, but the numbers are still low. They take about two gynecologists per year, and there is no nursing oncology program so far in the country. The other challenge that I think needs to be looked at is the screen, diagnose, and treat model. The model we are using in Uganda is the see, test, and treat, what we call the START model using VIA. But as I've said, the model is not fully operational, and only a few health centers can perform that. And you'll find that if center can perform VIA, then they cannot perform thermal ablation or cryotherapy or LEEP. So patients will still get lost to follow. And there are very few health workers who are trained in VIA. And even when they are trained in VIA, there is no quality assurance program. VIA is a good program, but the quality assurance component must be done very well. Otherwise, it becomes useless and waste of money. So I'm hoping that rights, as they do their VIA and thermal ablation, they also have a very strong component of quality assurance for VIA. Perhaps MEA has, VIA does not have. So in Uganda, that becomes a challenge. One of the issues here is can we as Busoga implement a see, test, and treat? Do we have the acetic acid? Do we have the spatulums? Do we have the colposcopes? Do we have the cryotherapy? Do we have the thermal ablation readily available for us to do a see and treat policy? What I want to talk about here is also which can be done is digital health strategy. This can be used to facilitate patient education. Most of us are stressed by phone messages about this program, this schedule. So can those be used also in Busoga to offer patient education? At least it's a campus screening. The service is available. And I'm sure if we network with the big networks, they may be able to do it for a good number of our citizens in the East. But also these health networks, can be used for health worker training, where we have those online courses we can develop locally and do. And I think I always work towards developing the strategies to help that. But also real-time consultation. WhatsApp is a digital strategy, and people use it to consult in real time. And we as gynecologists can give you answers in real time. I know I've received a couple of consultations or referrals from Busoga because of that. But also in real time, images that of the cervix, what we call digital cervicography, can be sent to somebody to see them in real time. You put a speculum, get a camera, photograph, or with your phone, send to a doctor somewhere. He tells you this is normal, this is cancerous, this is what, and then you can treat appropriately or refer appropriately. And then also can be used for collecting data. So we should, I think right now many of us have smartphones. The nurses have smartphones, and this can be an area where we need to think through on how we can collaborate to actually help our patients, but also help clinicians who are managing these patients. Interventions to increase knowledge and awareness among women. First of all, I think our health workers don't know much about cervical cancer. So
the real question is. By the way, I would have
somebody on the microphone. So health talks, IEC materials. In some countries, or even in some of us who do private practice, we send out personalized forms to invite women for screening, and they respond. We have radios in Busoga where we can do those health talks, the broadcasts, but also it was brochures that actually talk about the cervical cancer. So in terms of interventions, we already know, but we have not innovated well to market the cervical cancer screening and treatment in our local areas. You should be aware that Uganda has a national program for HPV vaccination, and the vaccines, in my opinion, if coverage is good, if they can hit 80%, this can be a target breaker. The challenge now in Uganda is that they're only targeting people between 10 and 14 years. However, there is evidence to suggest that even women up to 30 years can benefit from the vaccine. So we can test the VIA, it is negative, give them the vaccine. You may save a life later. And there is evidence to that effect. And some of the evidence comes from, this is a study that was done population level in Sweden, where they did vaccination and they looked at the risk for cervical cancer later. So they actually looked at 1.6 million women and girls aged 10 to 20 for a period of 11 years. Okay, and when they looked at that, they found the vaccine actually reduced the risk for cervical cancer in this group of women. And let us see what they actually found. Because this is of importance for us locally, that the vaccines actually work. So if you adjust for women who, what is that information? I wanted to look at that information. Sorry. Let me look for it. But generally, for all age groups, there was an improvement in or reduction in cervical cancer incidence. Okay, that we shall look at later. But generally, for girls between 10 and 14, the incidence of cancer was reduced 94%. For women between 14 and 30, that incidence was reduced. So one of the things we must strive or promote in Busoga is immunizing the girl child and women below the age of 30. Remember, we have lots of teenage pregnancies. We have a fertility high. Women can be targeted during that time for vaccination. So I will say, but as a wogu, AWOGO is the Association of Obs and Gyn in Uganda, and cervical cancer screening is one of our priorities, proposed priorities to pursue in the next year, or in this year and the next year. Those of you who came for the conference, we were invited by the PS to give priorities, and I think cancer screening is among those. And we shall do this through advocacy, developing material for education for both patients and health workers, and then developing or updating guidelines for use in cervical cancer and treating. But also we are open to collaborating with the Health Forum, and I know there is a new group which was formed, which is AWOGO East, so that we can link up and beat our heads and see how we can deal with this problem. I will beg to stop there and invite comments or questions. Thank you.